These patients weren't prepared for a diagnosis of cancer, and the reactions were as varied as the number of different cancers, from trepidation to dismay to humor. Behind the diverse reactions is a fear of the unknown. It seems we don't cope well with the reality of cancer. But advances in strategic treatment now bring us newfound hope for living with cancer in central Illinois. About 1.6 million new cases of cancer will be diagnosed in the current year. And the American Cancer Society predicts nearly 600,000 Americans will lose their battle with various forms of cancer this year alone. The Cancer Society estimates the four most commonly occurring cancers this year will be breast, prostate, lung, and colon cancers. There will be more than 200,000 cases for each of the first three cancers, far more than any other form of cancer. Individuals with lung cancer die at terrifyingly high rates. The lack of a good screening program is partially responsible for the high death rate in lung cancer. However, a new scanning technique brings hope for fewer deaths.
The Tri-County area for the state of Illinois is one of the higher parts in the state for actual incidence of lung cancer. Probably has to do with our professions that we have in this area, as well as our smoking histories that we have in this area.
Lung cancer is the third most leading cause of cancer in the United States, and it's the ~1 cause of cancer death in the United States. So it's preceded by prostate cancer, breast cancer, and then lung cancer, and then followed by colon cancer. Lung cancer accounts in 2013 for approximately 160,000 deaths, which is more than all of those cancers combined. The screening programs that exist for those other malignancies has brought their mortality rate down, and that allows lung cancer to be really a standout as needing a screening study.
If you look at overall cancer survivor for lung cancer, in the last 20 years we've made no progress.
By the time people usually present with symptoms of cough or shortness of breath and turn out to have lung cancer, it's too late to do a lot of things that we can cure them for. So what we're trying to do is screen for lung cancer earlier by finding with CAT scans smaller, tiny spots or nodules in the lungs. We could potentially cure those patients.
It's really difficult with chest X-ray imaging to detect early cancers. We have had CT scan for over 30 years, so why haven't we used CT scan to diagnose lung cancer early in a screening format? Well, the technology didn't exist to where we could perform a quality exam at a low radiation dose. And the mantra of screening exams is to first do no harm and then have a risk-benefit ratio that favors doing the screening study.
With recent technology improvements, physicians now have a low-dose CT scan that can deliver better resolution. To accompany that advancement, OSF St. Francis Medical Center has established a screening program for qualified older citizens who have a history of smoking.
This is a free low-dose CAT scan, low-dose radiation CAT scan for certain types of patients, exactly. Ages 55 to 75. They can be current smokers. If they've quit smoking, they've had to quit in the last 15 years.
The images are sent over to our workstation, which is basically a computer system, and we review the images. It could be anywhere from 2 to, say, 300 images that we review, and we look for any suspicious lesion that's suspicious for malignancy.
Once diagnosed, the treating physicians meet as a group to look at test results to determine the best course of treatment.
The lung cancer clinic really helped form to try to help bring together all the specialties and shorten the duration of time it takes a patient to actually get treated for their cancer once they receive a diagnosis.
When a patient presents with symptoms to the time of treatment plan, if that indeed turns out to be cancer, it averages around 90 days. At St. Francis, we have it down to 17 days.
It's important to have a screening. Stage 1 lung cancer does far better than stage 3 and stage 4.
Right now, surgery is an option only for about 30% of the patients that we see. With screening, we hope to shift that to about 70% of the patients having an early lesion that could theoretically be managed with surgery.
Robert Gordon had no problems with his breathing, but he chose to have a screening anyway. He expected to get a clean bill of health because he had quit his 2-pack-a-day habit.
The low-dose CAT scan showed a spot in his left upper lobe, and this prompted a further evaluation or workup. So he got a biopsy of that lesion, which showed a lung cancer.
Couldn't believe it, because I hadn't smoked in so many years, and I felt good. And so then I told my children I had lung cancer, and they were devastated, and so was I.
This spot right here turned out to be his cancer, and this spot right here did not actually have any cancer in it. It was a old infectious process for which he'd had. The great thing about the CT is it allows multiple views and multiple different types of imaging. This is the same CT scan except without the lung windows. What we look at in this situation is we look at lymph nodes, and what we really see, this is his big blood vessel in his body called his aorta, and we look for lymph nodes along his aorta, which would be little bumps, which we really, to be honest with you, don't see any enlarged bumps. There's a little node right there. He then was staged with a PET scan and an MRI, and then he was given a physiologic test called pulmonary function test to see how well he breathes. And once all that information was brought together, we then discussed him at our lung cancer clinic and felt that surgery was probably his best option, and that's when he then came to see me.
I saw Dr. Anderson, I think, on Friday, and on Tuesday I was operated on.
He had a localized lesion in his left upper lobe, did not spread to any lymph nodes, had not gone outside of his lung itself. And so I performed a left upper lobectomy on him.
Dr. Anderson told me he got everything. So I felt good about that, and I was in the hospital for about 4 days.
Your left upper lobe typically contributes about 20% of your total lung function. There's some little math that we can do and figure that out, and that's what I try to figure out when I look at his pulmonary functions. I look at what his pulmonary functions are now, and I say, okay, I'm going to take out his left upper lobe. This is what they would probably be after I take out his left upper lobe. And when he meets with me, that's part of the discussion that we usually have.
It's not quite 100%, but I don't really have any problems. I mean, I play golf, and I still do some work, and I go to the gym and work out, and you're short. You can tell that you don't have 100%, but it's not that bad.
This is what I work for, is to see somebody who's a year out doing well, back doing what he normally did before we even met. That's really what I want to see.
Lung cancer, if caught early, is curable. The same cannot be said for multiple myeloma, regardless of when it's diagnosed. But progress has been made using stem cell transplants that will add years to a patient's life.
Multiple myeloma is a cancer of the bone marrow, and in particular it's a cancer of a type of a white blood cell called a plasma cell. And these are cells that make antibodies, or what we call immunoglobulins, in the body. So oftentimes it's a cancer that's detected on the basis of having abnormalities in protein levels that are present in the blood. You can see something called a protein spike that is present.
They continue to do blood work every 3 months to watch my M protein level. And they said when it got to a certain level that we would start treatment.
The current standard that has been shown to be effective is to do this induction chemotherapy for a period of time, typically about 3 to 4 months that we use with the chemotherapy. And in patients that are young and healthy, that we then have a recommendation in most situations to move forward with something called a stem cell transplant. And in particular, this is called an autologous stem cell transplant, which means getting stem cells from himself.
August 3rd, they put a port in and drew stem cells. Took 2 days to, I think they drew 6.2 million stem cells.
And we freeze those stem cells to allow some recovery from the collection process. After that collection process is completed and patients have recovered, usually about 2 weeks to 4 weeks later, we bring them back into the hospital and administer a very high dose of chemotherapy that is designed to try to wipe out as much residual cancer cells that are present as we can, but also, unfortunately, that has an impact on the normal cells, the normal bone marrow. It wipes that out as well. So the role of doing a stem cell transplant is actually to rescue the body from those high doses of chemotherapy that are used in that situation.
We started the transplant here at Methodist on August 17th. Got 2 days of high-dose chemos. The third day I had off, and then the fourth day we started the transplant.
These stem cells are just administered via an infusion, similar to a blood transfusion that we do, and they have the ability to find their way back to the bone marrow to then repopulate and reestablish the normal blood counts that people need. After the transplant, people still have somewhat of a suppressed immune system though, and that actually can last for a longer period of time, 3 to 12 months, that we can still see some general decreases in the immune system. So there still are some susceptibility issues to infection that we see in that sense.
It was about 5 months recovery, and they just waited for my red and white blood cell counts to come back so I wouldn't pick up an infection.
The most important is the white blood cell, and that's because the white cells are involved in fighting infections.
Dr. Gerstner traced everything. He's still tracing. We pulled blood every 3 weeks. He's watching my M-spike. It's the lowest it's ever been since 2007.
Commonly for patients with multiple myeloma, we also then go on to do what we call maintenance therapy after the transplant is done in an effort to keep the disease in remission for as long as we can, and in part the hopes that we can develop other new treatments that may come along and be more beneficial. In this particular instance for multiple myeloma, stem cell transplant, autologous stem cell transplant is not a curative process.
I understand it's not a cure. We got to have hope, and hopefully we prolong and we can get more drugs to help multiple myeloma.
His prognosis is generally good, although certainly not a normal individual's prognosis. Anytime with a myeloma, the lifespan is still unfortunately reduced, but that we have every reason to hope and believe that he'll live for another 10 to 15 years. And as we develop more and more treatments for multiple myeloma, my hope is that we continue to push that envelope further and further.
Well, you got to keep a positive attitude. You can't get down. You only got one chance.
Sarah Adams credits her upbeat approach with helping to recover from a breast malignancy that measured 6 centimeters across.
I received the call on May 10th of 2013 that I had breast cancer.
The disease was already more advanced, and very often we find very small tumors. Hers was a larger tumor.
So my case was taken to the what they call tumor board, and it was discussed amongst not only the oncologist but also the radiologist and the surgeons, and that really made me feel good that there was multiple people weighing in on my course of treatment.
Her tumor was so-called HER2 positive, which means it has a receptor which tells us it's a more aggressive kind of cancer, but we also know if we treat that specifically with a targeted medication, that she has a great chance to survive the breast cancer and go on with her life.
At first, they had thought that they could start chemotherapy and shrink the tumor. And when I met with my surgeon, he and I were really more on the same page that we just wanted to get that out. And so I opted to have surgery first and then follow with the chemotherapy and then follow up with radiation.
The chemotherapy is in general like a 5-month process. And because of the kind of breast cancer Sarah had, which was HER2 positive, we added trastuzumab, which is the targeted medication. That medicine is given for a whole year.
Sarah did not complete the entire 5-month sequence of chemotherapy because she developed some complications near the end of the treatment.
My fingernails had really started to become compromised. They started to lift off the nail bed and were quite painful. I actually ended up having 4 of them surgically removed just to provide some relief, and also because I was afraid of getting a bacterial infection.
Sarah's doing great, so she's cancer-free. We have no evidence that there's any breast cancer in her body right now. She has done the major part of her treatment. She's still on the hormone pill. After she has completed the hormone pill, her chance to get breast cancer is about 10%.
So today I can say I'm cancer-free, and I'm just trying to get back to what they call a new normal life.
Detection was fortuitous in Sarah's situation. Her cancer was diagnosed because she had a mammogram, but she got the mammogram earlier in her life than she had planned.
We recommend for every woman age 40 and older to have yearly mammograms. And many physicians start between 35 and 40 to have like a baseline mammogram, and then they start the regular mammograms at age 40.
The first time that I had a screening was really at the recommendation of a nurse practitioner at an office visit. She asked me if I had had a mammogram, and my first comment was, "I'm not 40."
There are genes that can be predictors for some families with a history of breast cancer.
BRCA1 and 2 genes, these are 2 genes we have identified in families, and we know these families have a very high risk for developing breast cancer. So if a patient has a family member with that genetic mutation, we definitely recommend to be tested as well. And if one has the genetic mutation but doesn't have breast cancer, the risk is about 50 to 80% to develop breast cancer during lifetime.
I did have the BRCA test performed, and my results were negative.
We know that 2 things are risk factors for breast cancer: overweight and lack of exercise. So we are focusing on these two things, and we have a nutritionist at the Mills Breast Cancer Institute to help patients to keep their weight stable.
So the lifestyle changes that I've made so far, having been through cancer treatment, are increased exercise and a change in diet.
Much like the Tumor Board, the group of doctors that jointly determined the best treatment for Sarah, a team of medical experts developed the therapy program for Roger Hawk, who had been diagnosed with squamous cell cancer.
We have what we call a multidisciplinary tumor board conference, where we bring the specialists from all the different specialties together in a meeting room, and we look at all the radiographic imaging, the pathology, and sort of the nuances of each particular patient's case.
The person on this end of town and the person on this end of town and the person in this building get together to look at cases. And I thought, well, it has to be about communication. And I like that factor.
And so we get input from each different physician and the pros and cons of each different type of treatment, whether it be radiation therapy, surgery, or chemotherapy, and come up with the best treatment plan.
Roger had squamous cell carcinoma on his left cheek. It is a cancer that originates in the epidermis. Surgery was only a first step in his treatment plan.
The surgeon was not able to remove the tumor altogether, completely. And because of the microscopic cells that were left behind, we needed to offer radiation therapy as insurance that it wouldn't grow back. When you want to treat with radiation therapy, you want to target specifically that operative bed or the tumor bed where those microscopic cells are and where they could potentially spread to. So the problem is that it's in close proximity to the tissues that you want to protect. For example, the eye, the mouth, the nose, the brain, the spinal cord, the esophagus. All those structures are within the head and neck, and you don't want to damage them or irritate them much from the radiation. So using tomotherapy, you can minimize the dose that those surrounding tissues get. It uses a built-in CT scanner into the treatment machine, and you're able to hit the target from 360 degrees around, and you create these what we call multiple beamlets. And so the beam is broken up into 1,000 different beamlets. And in that way, you're able to turn off certain beams so that when the parotid gland or the mouth or any critical normal tissue is within the field, you can shut down or limit the dose to that area while still hitting the target.
I'm in there like 7 minutes, but it's a very intimate world. It's not a fearful world. It's not a scary world.
We had to make sure that he held still every day, because if he moved during the treatment, we would obviously miss the target.
You get the mask, that's the mold that they have to put on you when you have radiation.
That mask is locked onto the table, so that assists in mobility, and we're able to make those translational shifts in the couch as it goes through the hole or the torus of the CT scan treatment machine or the tomotherapy machine.
So they put me on that table and they did what they had to do. The routine was always the same. I had a mark on one side, I had a mark on the other. It was all to make sure I was square and so that they hit this spot.
Roger had 33 radiation treatments after his surgery. While radiation therapy is effective, there are still side effects, although they are often less pronounced than with older radiation programs. Side effects may vary by patient. In Roger's case, he did not suffer much fatigue, but did face two other issues: a temporary loss of taste and a burn where his cheek and neck were radiated.
The eventual result was this burn just kept getting more serious, like first degree, second degree, third degree, and so it was very raw.
The redness is like a sunburn effect from the radiation beam. And so the skin can get red, it can peel, it can flake, it could potentially blister, and just what you would expect with a typical sunburn.
Because it affected my salivary glands, one of the side effects, and I knew this, was I would possibly lose my taste during the treatment process and for an unpredictable amount of time after it.
That meant that he would get dry mouth or thick secretions, thick saliva, whatever's left. And when it gets dry, there's a loss of taste, and there's also a possibility of maybe getting some dental cavities, because the normal function of saliva or spit is to wash away the bacteria. So the patient's fatigue is caused by their immune system reacting to the radiation therapy. And so certain mediators and antibodies are released, and that causes a fatigue in the body. And as we start to get tumor kill, the response to that tumor kill is a sense of fatigue or tiredness. What we've found is that compared to the previous radiation with tomotherapy, patients can sail through treatment with a lot less side effects. Previously, we'd have to maybe break their treatment. They would get such a severe sunburn of their skin or blistering, we had to pause or take a break from the radiation. Now we're able to get patients through without that break.
Right now, medically, I see the doctor monthly. That is about, this is my first anniversary for the month of February it was. And next I will go probably to a 2-month check. I'm with the dermatologist. I'm on a 3-month check.
We have him come in for periodic checkups to monitor any potential side effects and to make sure that he's still what we call disease-free or no evidence of disease.
And I just met with the radiologist, and I've obviously gotten on her nerves, and she said to me, "You don't have to come back for a year." And that's good. Medically, that's good news.
Roger's humor helped in the recovery process, as did Sarah's positive disposition, as did encouragement from Scott's family.
My wife was great support. Our church was great support. We had a lot of family and friends that helped in time of need.
But lifestyle changes are as important as attitudinal approaches. For example, dietary changes can help after and even before cancer is diagnosed.
The importance of eating around the parameter of the store is that you're going to get your most natural sources of food that way. What I want to do is actually reduce inflammation in your body, and added sugars and preservatives and added bad unhealthy fats will actually increase inflammation in the body. So what I really want you to focus in on is all of the really rich nutrients that you get from fruits and vegetables, as well as nitrate-free meat products and cheeses, and a lot of really good vitamins and minerals. The richer the color, so a blackberry, blueberries, raspberries, they are going to give you more nutritional value than, let's say, something of a lighter color like cauliflower. If you're eating the skin, you should buy it organically. Just because all of those pesticides really seep into that fruit and vegetable through the skin. But if it has a really thick skin, like an orange or a pineapple, those types of things you can actually buy conventional. With a lot of your moldier cheeses, those are aged cheeses, and if they're not pasteurized, you're actually getting a lot of live and active cultures, much like yogurt, so you're getting a lot of good probiotics in them. Your leanest and best cuts of meat are gonna be your sirloins, as well as your round cuts. Things to really look for when you're going for a deli meat is to ask for ones that are nitrate-free. Nitrates are actually a known carcinogen. They add them in as a preservative, but a lot of your deli meats will have nitrates in them unless you ask them not to take the ones that have the nitrates in them. For nutrient value, I would probably go with 100% pure orange juice. With the pulp, you'll get extra fiber that way. When you're looking at breads, if it says 100% whole grain, that's the best one to go with. They kind of trick you with the 10 grain, 15 grain, 7 grain breads, because that necessarily doesn't mean that it's whole wheat. Just look at the first ingredient. If it says 100% whole wheat, then that's where you're gonna get a lot of that benefit.
The fear is easing, the unknown is better understood, and treatments have progressed. We have taken steps forward in our fight against cancer, yet there are many steps that lie ahead.
We want to have control of our destinies, and I do think in the end we'll be able to prove that these are all great things to do. We just have not refined our interventions and told people how to do it.